There are 3 reasons why you don't want to intubate diabetic ketoacidosis unless you absolutely have to, and these are cardiovascular instability, ventilatory requirements, and neurological monitoring. So a brief recap, diabetic ketoacidosis is where a lack of insulin means you cannot take sugar out of the blood and use it for respiration. So organs have to use something else. So they resort to glycolysis, where they produce lots of lactate, also metabolize fat to produce lots of fatty acids and ketone bodies. Now, these are acidic in nature, and that's why you get diabetic ketoacidosis as a name. So you're left with a patient with lots of sugar running around in their blood. This sugar all gets filtered out in the kidney, in the proximal convoluted tubule, and then the kidney tries to bring it back into the blood by reabsorbing it. Now, if you've got lots and lots of sugar, you quickly overwhelm this mechanism, and so the sugar stays in the tubules and ends up in the urine. But sugar is very osmotically active, and it drags water with it. So you end up getting what's called an osmotic diuresis. The sugar pulls water out and the patient becomes very dehydrated because they urinate a lot of water out of their system, and they're often dehydrated already, and this just makes that worse. So by the time they present to hospital, they can be 8 to 12 litres deficient, very, very hypovolemic and very cardiovascularly unstable. So if you then try and intubate them and you give them anesthesia and muscle relaxants, you lose all of the sympathetic tone that was maintaining their blood pressure. You take away all of that adrenergic drive that was keeping them vasoconstricted and keeping their blood pressure up, and their blood pressure absolutely tanks. These patients need enormous quantities of fluid, and you need to try and avoid giving them anything that's going to take away that sympathetic drive unless you absolutely have to. Now, these patients have a horrible metabolic acidosis, and that's a combination of the ketones and the lactic acid that they're producing that is causing them to be so acidic. Now, to compensate for this, they do what's called Kussmaul breathing, which is deep, sighing, gasping breaths where they very effectively get rid of lots and lots of carbon dioxide, and they produce a respiratory alkalosis to compensate for their metabolic acidosis. How well they do this depends on the person, but essentially they are breathing very hard to get rid of lots of CO2 to try and compensate for this acidosis. If you look at this blood gas, you can see this patient is breathing so hard that their PaCO2 is around 1. Now, if you put this patient on a ventilator, their lungs become a lot more inefficient. They lose all their ventilation perfusion matching because you're now positively pressure ventilating rather than negatively pressure ventilating. They're not sucking air in anymore. You are forcing it into their lungs, and it's a much less efficient way to breathe. You will not be able to ventilate them hard enough to get their CO2 that low. It's just not physically possible with a normal ventilator. So as a result, their acidosis will get worse. Now, that's before you take into account the time during intubation when they're not breathing at all. So once you give them the muscle relaxant and you wait your 45 seconds for them to stop breathing and the muscle relaxant to get to the vocal cords and allow you to intubate, their pH will steadily drop because their CO2 will rise and all of that compensation goes out the window. So you will not be able to ventilate them hard enough, and that apneic period where they're not breathing will make their acidosis really, really bad. So you really don't want to intubate and ventilate them. You want them to keep breathing as they are, because they're doing a really good job. If their CO2 is really low, it means they are breathing very effectively. They may look like they're very short of breath and they may look very uncomfortable, but that's okay. They are fixing the problem themselves. It's only if they become exhausted and their CO2 starts to rise, then ventilating them becomes a better idea. But anytime their CO2 is really, really low on the blood gas, let them carry on. They are doing a better job than we will ever be able to do with a ventilator. Now, the last thing is the neurological monitoring. If someone's neurological status is affected because of their diabetic ketoacidosis, it should get better as you treat it. If you intubate them and you anesthetize them, you lose all that monitoring. You have no idea if their neurology is getting any better. So those are the 3 main reasons you don't want to intubate diabetic ketoacidosis. If you're interested in learning more about diabetic ketoacidosis, you can check out our article on anesthesia.com, which contains everything you could want to know for the exams.